Good evening. My name is Dr. David Doman, and welcome to another edition of Housecall. What's new with brain tumors? Find out more right now. My guest this evening is Dr. Joseph Watson of MedStar Georgetown Medical Center. Joe, welcome to Housecall.
Thanks for having me. I really appreciate the opportunity to speak.
My pleasure. So tell our viewers briefly about your professional background.
Well, I'm the medical director of the Comprehensive Brain Tumor Program here at Georgetown, MedStar Georgetown University, of course. And I spent a lot of time in Virginia, trained in Richmond, and then just down the street here at NIH, where I really got into the tumor workings, a lot of the research side. How do we attack these tumors? And then my travails have taken me all over the country, but I found a real home here at Georgetown.
Very nice. And what is your academic title at Georgetown?
Well, I'm a professor of neurosurgery, but my title here is the director of the Comprehensive Brain Tumor Center, which is a relatively new program here at MedStar Georgetown.
Very nice. So briefly tell our viewers, how common is brain tumors, and in particular brain cancer, in the USA?
Tumors in general inside the head are very common. I think we've all heard about it in the news. Most of us know people that have had brain tumors. And, what we end up hearing a lot about are the bad ones, of course. Brain tumors in general encompass a lot more than just the real bad tumor. So, I hope today we can shed some light on all that.
Compared to other cancers, though, breast cancer, colon cancer, etc., where does it rank? How common is it?
It's very, unfortunately, deadly. And you may have heard even Biden say, that he's trying to launch an all-out attack on brain cancer. And the frank reality is that even though they're not that common, we have a very difficult time curing them. Our results, the number of cures has gone up a lot lately, and that's what I'm excited about here to tell you about. But we still have a very long way to go, unfortunately, and hopefully we'll hit on some of the reasons.
Is it your impression that brain cancer is more common now than it was 30 years ago, or are we just better at picking it up?
Well, we're definitely better at picking it up. There's no doubt about that. Our technology is amazing, namely CT, then MRI, and now we have even variations of those that are amazing. And the rule is, if you pick something up early, hopefully you have a better chance of curing it. With brain tumors, there's a problem with that. That's not actually the case necessarily. So it does take it takes a lot of understanding. I think one of the focuses of my job is to help people understand the problems that we deal with and why it's so difficult.
Is there any particular risk factors or etiology for brain cancer?
The reality is we don't have any clear or known risk factors for brain cancer. We know there's some genetic component. We know that environment can influence the development of brain tumors, radiation exposure, for instance. But we don't have clear risk factors like we have in some other cancers. And that's what makes it so out of the blue often when we get a diagnosis of a brain tumor that's cancerous.
There's been a lot of controversy since the technology was developed that cellular telephones could be a risk factor for brain cancer. And certainly the cellular phone lobby aggressively opposed any legislation dealing with that as a risk factor. What are your thoughts about it? You're in the middle of this battlefield.
Well, I get that a lot, unsurprisingly. And you can imagine that the incredible ubiquitous use of cell phones. Everyone's got them, all over the world. And so it gives us great pause. It's been an area of interest. I used to work with a physicist at Lawrence Livermore in California. And he had a proposal for a handheld radar. And one of the criteria that he used to get it through all the committees that assured the safety of this device was that it used 10 times less radiation than a cell phone near your ear. So it gave us great pause, as I mentioned. We were real worried. And subsequently, thanks to my colleagues around the world, there have been several large studies. When we look at scientific studies, we value them based on how they're designed. And the best are sort of randomized and prospective studies that look at this. Well, you can't randomize it, but what we've looked at prospectively is the influence over time of cell phones on the incidence, occurrence of brain tumors. And the great news is, with lots and lots of data, it hasn't been shown. There doesn't seem to be a link. So that's, very comforting because we're all worried. I'm worried, everybody's worried. So right as of now, we can rest assured there doesn't seem to be a correlation there.
So just to restate what you've said, then, it's your impression the incidence of brain cancer today, in the midst of the popularity of cellular phones, is no different than what it was before the technology was developed.
Right. Yeah. And the reason we can say that is that we've had good imaging technology that preceded the cell phone. So we do have pretty good data, lots of numbers that indicate that. But yeah, I always worry. It doesn't stop me from worrying. But no, right now we're okay.
Good. Briefly, I know that many cases of brain cancer or benign brain tumors are picked up fortuitously. Patient has no symptoms per se. But what are some of the symptoms of brain cancer that should alert a patient that they may want to get further evaluation?
That's one of the fascinating things about the brain, is it doesn't feel pain for itself. And therefore, something can be growing in the brain and your brain doesn't know it. It can't feel it for itself. It's a bizarre thing. So, we don't say, oh, you have, headaches from a small tumor. No, but we do worry. Headache is a symptom, it can be, of a brain tumor, particularly certain types of brain tumors, and particularly when they've gotten to a large size. So we always, whenever we hear headache, and someone that's not prone to headaches, we do think about it. You do a risk benefit analysis. It's fairly safe to get an MRI just to make sure it's not a tumor. But frankly, the headaches are so common and tumors are not common. It's very rare that a headache is the first sign of a tumor. So I don't want people to panic when they have headaches. But there are certain qualities of a headache that make it more likely to be related to a tumor. And those include headaches that wake you up in the middle of the night, headaches that you never had before, headaches that are really bad in the morning when you wake up and don't go away. And then there are headaches that can be associated with nausea and vomiting, a progressive syndrome. That worries us. And we almost always recommend imaging and workup for that. Now, there are lots of other things that can happen. As I mentioned, the brain, though it doesn't feel pain, a tumor, so anything in the head can cause a derangement of the brain, and that can manifest in so many ways: deficits, problems, abnormal behavior. seizures. These are things, particularly in people my age, middle age, or older. If you had a seizure out of the blue, well, that really worries us. There could be an underlying tumor. So these are the things that we need to watch out for.
We're going to pause briefly for a public service announcement. More with my guest, Dr. Joseph Watson of MedStar Georgetown Medical Center, and we're discussing brain tumor. We'll be right back.
We're all just trying to keep things running for those who rely on us.
Ready?
That's why we don't have time to be sick with the flu. And especially this year, no one has time to get sick. Get a flu shot for yourself and those around you too.
We're back. My guest this evening is Dr. Joseph Watson of the MedStar Georgetown Brain Tumor Center. Joe, when we paused for the public service announcement, we were discussing the presentation of brain tumors and brain cancer in particular. One thing I want to clarify for our viewers is, what is the difference between a primary tumor and a metastatic tumor?
Yeah, thanks for bringing it up. When we hear the term brain tumor, really, tumor just means a thing. And so it's a term used for a lot of different entities, tumors inside the head. And the most common, frankly, are tumors that have spread from somewhere else. For instance, if you have lung cancer, there's a very high rate of it spread to the brain. Luckily, to balance that out, one of the other common types of tumors in the head is something called a meningioma, which is typically benign. Now, they can act in bad ways, but they are potentially curable. So it's a very different entity than what we're primarily going to be talking about today, which is the tumors that start in the brain matter, in the brain substance. We call those primary tumors, CNS tumors. Now, a meningioma, although it starts in the head, does not arise from cells of the brain. It arises from cells of the coverings of the brain. So it's very different. But tumors that arise in the brain are rarely, almost never, tumors of neurons. We think, oh, the brain's all nerves, right? Neurons. Well, no, actually, the cells that give rise to tumors are these cells that support the neurons. These we call them glial cells. So you'll hear the term, and we'll use that probably today, of a glioma. A glioma just means it's a tumor of a glial cell. And the most common tumor is from a glial cell known as an astrocyte, and that's an astrocytoma. So we'll often use terms almost synonymously of astrocytoma, glioma. Glioma is a more general term. Now, there are other glial cells, oligodendrocytes, that provide insulating, and we have tumors of those, oligodendrogliomas. We have tumors of the lining of the ventricles, ependymal cells, and so on. But by far, the most common tumors are those that arise from the astrocytes, and those can be tough. And when you hear the term brain tumor, and we're talking about a primary tumor, it starts in the brain. The most common tumor in adults is something called a glioblastoma. And it is a form of astrocytoma that is the worst actor. We grade astrocytomas on a scale of 1 to 4, and a glioblastoma is a grade 4. So unfortunately, it's the most common, and it's also the most difficult to deal with. So a lot of what we talk about and a lot of the numbers we hear, the statistics, are weighted in terms of these bad tumors, these glioblastomas. So thank you for allowing me to give that sort of platform baseline for the further discussions we have here today.
Great. So with that as a background, let's say a patient has been diagnosed with a primary astrocytoma, a type of brain cancer. How do you approach evaluating them and then determining if they're a surgical candidate? Well,
it is a team approach. Fortunately, that's one thing we've worked on here at Georgetown, put together an excellent team. And I'm a surgeon, so obviously there's some role for surgery. And, you know, it's a very interesting problem in that we have a tumor that's causing trouble. We'll see it on an MRI scan. The patient can see it, we can see it, everyone can see it. And so you say, okay, well, let's get a surgeon and have them cut it out and everything will be fine. And that's true in some cancers. And what's deceiving about glioblastoma or high-grade gliomas is that that doesn't work. You cannot cure them with a surgery. And it's terrible for me because that's my job. And so we have to ask ourselves, what is the role of the surgeon in the care of these patients? And almost always there's a role. So I think we should start there. And often I'll be one of the first people to assess a patient that's been discovered to have one of these tumors. And my job is to say, okay, I'm a surgeon. I need to be able to get an accurate diagnosis, and that requires a biopsy, some form of sample of the tissue. Well, that's a surgery. And then the second sort of thinking that the surgeon has is, okay, well, can I remove the tumor that I can see? And is that useful? Will that help? Well, that often does. You know, tumors, we mentioned the brain doesn't feel pain. So by the time you find them, often they're big and causing other trouble. And a lot of times by removing the tumor you can see, you alleviate symptoms. Someone who can't talk, well, they can talk now, or someone who's having trouble moving one side, and after surgery, they can now move better. So these are the roles of surgery. So we make a tissue diagnosis, which means we take a sample, give it to the pathologist, and they give us a final answer. And that's really important these days. And hopefully we'll have time to talk about that later. And then obviously the second part is to remove what we can see if we can do it safely. You know, a tumor, what we see on an MRI is not doing any thinking, right? But here's the thing that almost even my colleagues have trouble understanding functionally, is that what you see on a scan, there's a ball. It's a confluence of tumor cells. But throughout the brain, there are cells everywhere, microscopic cells. It's as if you stuck a piece of soap in some water and jiggle it around. If you take the bar of soap out, the water is going to have soap in it. It's not going to be, you know, free of tumor cells. So surgery, you know, a lot of times what happens is someone's enthusiastic from a surgery standpoint and they want to just go take it out, get all of it. Well, the problem is it can end up in a bad situation where you've created a problem in the brain that the patient didn't have before. You've created a deficit, something that's going to make life harder. So that's where surgery's role is very important, not to do enough to help them on their way, but and establish the diagnosis and help with symptoms, but not to harm them. It's really important. And I'm afraid that it's still a difficult concept for many people, including colleagues of mine.
Sounds like a real challenge, and that's why you need the multidisciplinary approach.
Well, exactly. So, you know, if I see someone who has a terrible tumor, and I know I can't cure them with surgery, well, you know, everyone's throwing up their hands. Well, no. So fortunately, we have a great team. And you know, what I tell people, when I started, the neurosurgeon was the whole team. Essentially, we were the oncologists. We directed everything. We did the surgery. We sent them for radiation. We followed them up. We did reoperations. We did everything. Now, that's not the case. In fact, what we have in our team is a quarterback, and that quarterback, if you don't mind a football analogy, is the oncologist these days. Well, when I started, we didn't have any chemotherapy that was effective. We didn't have gene treatments. We didn't have any of this. And so, but now we do. We have some great therapies, and my patients live so much longer now. It's just a better system. So the oncologist is the quarterback. I play a role, of course, usually right up front. Then really we hand off to the oncologist. And we have a great oncologist here, fellowship trained, Dr. Camiloti Pastor, and she's wonderful. And her job then is to make sure that everyone is coordinated in the care. And often that care includes some form of chemotherapy. It often includes another physician, radiation doctor, experts in the field of radiation physics and science. And we also have ancillary support, nurses, that help us navigate all these appointments that are going to be required to beat these things, to beat the tumor.
You mentioned chemotherapy, immune therapy. What are the challenges delivering that? And during your answer, please educate our viewers about something called the blood-brain barrier.
Right. So thanks for mentioning that. I alluded earlier that, well, chemotherapy didn't used to work. Well, the problem is the brain is very good at excluding toxic substances, as you can imagine. And in traditional chemotherapy, it's very toxic. So, our brains did a great job excluding it by something called the blood-brain barrier. It's a characteristic of the blood vessels in the head that's different than the rest of the body. And so it's great until you have a tumor and you need to get some type of chemical into the brain to kill the tumor, but the brain won't allow it. And so we've been working on that for many years, but fortunately, we've been able to find a few instances where there are chemotherapies that cross through and are effective in treating tumors. So that's what's been a great breakthrough in the last 20 years. And more of that is occurring almost daily, it seems, because we're finding other ways, a non-traditional chemotherapy that's not poison. In other words, it's biologic. We're targeting something in the tumor that makes it a tumor that's specific to the tumor, helps our body fight it. It's really kind of a bit of a revolution there.
Tell our viewers briefly whether all radiation therapy is the same.
Well, no, radiation therapy is very different. And radiation is a more traditional therapy. I think I mentioned earlier that we used to use it. We do have better ways now. Radiation is designed like chemotherapy to kill dividing cells preferentially over the normal cells. But the brain doesn't like radiation, so we have to be very careful with it. What we've been able to do, really in the modern era, is use more targeted radiation, these so-called cyber knives. It sounds like surgery, but it's not, it's radiation. And it uses something called an alpha particle, which is very hard to control, but we figured it out type of radiation. And what's even newer and not so much new as in more accessible now is something called a proton radiation, which uses a different particle with different characteristics of how it emits its energy. And what that allows us to do is protect the brain even further. So these things, what's new is being able to save normal brain or more normal brain so that your quality of life is much better. And that's been a real breakthrough for us.
We're going to have to stop there. Joe, this has been a terrific interview. Thank you. If our viewers have any questions, how can they reach you?
Wow, I'd love it if they would call or, get a hold of us in the office or in the tumor program. My office over in Vienna, we have offices here in DC and in Vienna. So I'm sure we'll put something up on the screen at the end. I don't want to go into it, but I would love to talk. It's my favorite subject. I hope I can help educate people.
Thank you for joining
Look
us
forward
on
to
House
that.
Call. My thanks to my team at the studio for making this show happen, and my thanks to you, the viewer, for joining us this evening. You can reach me at my practice website, also listed on the bottom of the screen. Let us know how we're doing. Our next show is going to be an exciting one. I'm interviewing the pain management team from Holy Cross Hospital in Silver Spring. It's going to be an important show. See you then next time for another edition of Housecall. Good evening.